Bene, oppala. Mi sa che adesso è un tantinello alto. Allora, Pierluigi vi ha portato la sua esperienza romana. Lui, giusto per inquadrare il personaggio Pierluigi Buccini, Pierluigi ha dedicato la sua vita alla professoressa Catricalà, perché lui trascorre 5 ore al giorno, dalle 8 alle 13, a fare mappature. Cioè lui è il suo lavoro, per cui ha una capacità impressionante morfologica anche di vedere queste piccole variazioni, che poi tanto piccole non sono al follow-up. Harald Kittler, lui invece ci porterà la sua esperienza di Vienna. Non so, immagino che tutti voi lo conosciate. Harald è quello che più di tutti ha studiato, ha cominciato a studiare un bel po' di anni fa la problematica controllo digitale dei pazienti con nei multipli, per cui sentiamo da lui qual è l'approccio, what is the approach to the patients with multiple nevi.
Thank you. Can you hear me? Yes. Can you hear me? Yes, well, unfortunately my Italian is not very good, although my grandmother was Italian. She died before I was born, so I was left with German and English. So I will speak English slowly so you can understand me. I will show a lot of images, so I hope you can draw a lot out of the images. Patients with multiple nevi, and the question is, which lesions should be examined with dermatoscopy, which lesions should be monitored, and which lesions should be excised. And I hope I can give you the answers now, or at least how we do it in Vienna, which might be a little bit different from you. This is a patient with multiple nevi. You've seen many patients, and it's easy to diagnose the melanoma here with the unaided eye. Where is it? Here. We don't need dermatoscopy. If you have a close-up here clinically, you can diagnose the melanoma here. Do you need dermatoscopy? No, no. But we do it, of course, just for aesthetical reasons, but for nothing else. But we do not need dermatoscopy to diagnose it here. When I was 28 years old, this is a long time ago, when I started to be a resident, melanomas looked like this in our department, maybe also in your department, but they were obvious melanoma. Nobody did dermatoscopy then, but these melanomas should have been diagnosed much earlier, and now we can diagnose them much earlier. So if we look at the development of melanoma over time, the clinical diagnosis with the unaided eye is good for those melanomas. And those melanomas started small. Every melanoma has to be small at some time. Every melanoma starts as 1 millimeter melanoma, 2 or 3 or 4. But usually we don't diagnose them then. And in older days, the dermatologists thought all melanomas look like this. But that is not true, because they couldn't diagnose melanoma at this stage. And the clinical impression also is a method of screening for dermatoscopy. Which lesions should be looked with the dermatoscope, looked after. So this is the ugly duckling approach, already presented by the colleague. But the ugly duckling approach, according to my opinion, is mainly for excluding false positive when the dermatoscope uses for clinical lesions. For example, here, ugly duckling. We need the dermatoscope to exclude that this lesion is a false positive. What do you think? Is it a melanoma or not clinically? Could be. Now, dermatoscopy. What's your diagnosis? So exclusion of false positive by dermatoscopy, because this was a false positive on ugly duckling. Another example. Clinically, ugly duckling. Clinically, dermatoscopy. Well, you excise it, but it's a false positive. It's a combined congenital nevus. There is symmetry. It cannot be more symmetric. Another example, ugly duckling, this one, it's the largest one. Dermatoscopy, what's your diagnosis? It's a nevus, yeah? So the main impact of dermatoscopy with ugly duckling is to exclude false positives. Yeah? The ugly duckling sign also fails in some situations. I mean, there are so many seborrheic keratosis, there is no sense in ugly duckling here. You miss the melanoma if there is one. Also here are so many ugly ducks, you cannot even count them. This is a very ugly duck, another melanoma, another one. Too many ugly ducks. And this guy has also many ugly ducks, and you don't know where to put the dermatoscope. And this lady, where's the ugly duck here? Is it this one, or this one? Where should you put the dermatoscope? If you put it here, you will miss the melanoma. You see it already, but you do not recognize it. Selection by clinical criteria prevents detection of melanomas that miss clinical criteria or have no clinical criteria. We use the Sherlock Holmes approach. This means always on highest alert. Look at every lesion, even if they are small. Now let's have a look at the lady again. Let's look at this lesion clinically, dermoscopically. Skip it or not? Skip it. Next lesion clinically, dermoscopically. Skip it. Next one. Next lesion, 2 lesions clinically, dermoscopically. Okay, next one. Clinically, dermoscopically. Okay, next one. Clinically, dermoscopically. Okay, next one. Clinically, dermoscopically. Eccentric hyperpigmentation, we would call it atypical nevus. But what makes it atypical? Our diagnostic uncertainty. The nevus itself would not say, I am atypical. No. We think it's atypical because it may be an early melanoma. But there is no clue to melanoma here. It's not a melanoma. Another lesion clinically, dermoscopically, one pattern, reticular pattern, central hyperpigmentation, skip it. And then send the patient home. But you missed the melanoma because you did not examine the small lesions. The melanoma is here. Here is the forearm, and here is the melanoma clinically. It is smaller than 6 millimeter of the ABCD rule. It is not asymmetric. It is not multicolored. It's small, and it's a melanoma. Why do we know? This is dermatoscopy. There is chaos, multiple patterns, reticular pattern structureless, and there are pseudopods. There is no doubt that this is a melanoma. And if you doubt, this is the histopathology. It's not a melanoma in a nevus. It's an in situ melanoma. Small, but it is. So you can diagnose it with dermatoscopy, but only if you look at it. So we can diagnose melanomas here because we look at small lesions with the dermatoscope. And if you don't look at small lesions, you will lose the higher accuracy that you gain with dermatoscopy. Only if you look at small lesions, small and flat lesions, you will receive a higher diagnostic accuracy than with the unaided eye. So how do we efficiently screen patients with multiple lesions with the Sherlock Holmes approach? I mean, this has to be very quick because you don't have time. There are another 100 patients waiting outside your room, and they want all to come in, and you don't have time. Well, what Chappie told you about, does it look like melanoma, is practically pattern analysis, and we do the same. We screen by pattern analysis. What does it mean? Is there chaos, which means asymmetry of pattern or color? If no, skip it. Is there chaos? Then we look for a clue to melanoma, and then we look closer. And by this, we can screen many lesions. This is what Chappie told you. It's pattern analysis. An example, clinically, chaos, yes or no? No, symmetry of pattern and color. Next lesion, clinically, dermatoscopy, chaos, yes or no? No, symmetry of pattern and color. Clinically, dermatoscopy, chaos, yes or no? No, symmetry of pattern and color. Clinically, small, what? Asymmetry of pattern and color. There is chaos, and now we look closer, and we see a very thick pigment network, and we excise it, it's a smaller melanoma. By this, we can screen many lesions in a short period of time.